Now, with the ever-rising tide of dementia, new or strengthened services are required both now and in the near future, and workforce development is at the heart of it. So first of all, meet Malcolm, and I'd like to focus on what carers and people with dementia look for in quality support and care, which help both of them to attain quality of life. And what I say now is drawn from my own experience as a carer and what I wished I'd had in my backpack of knowledge at the time. So just a reminder here about caring at home. 2/3 of people with dementia are cared for at home, and this throws the weight of providing support and care for people with dementia onto family carers and domiciliary care staff. And at the moment, of course, there's an accent, quite a reasonable accent, on raising the diagnosis rate. But for goodness sake, there's no point in having more diagnoses if there hasn't been an equal rise of provision of support for the person with dementia and their carer at home, and a strengthened domiciliary care workforce. And I foresee in the future that care homes will be full of the oldest old, people in their 90s and 100s, whose children may be in their 70s and 80s, may be themselves too frail to care for them. And so people with dementia under 85 or so may well have to be cared for at home because there ain't any room for them unless there's a massive increase in care home building. And care and support begin at the point of diagnosis. But too often, there's a huge gap in support. You get a bit of it at diagnosis, and then there's a great gap until you come to use traditional services. Now, that needs to be bridged as a real priority by well-trained staff. Carers want to do their best for their loved one, but too often, it's unwittingly giving the wrong kind of care. And here are a few examples. Forever contradicting or correcting. Malcolm would say, when we went to the supermarket on Tuesday, and I'd interrupt, say, no, it wasn't Tuesday, it was Wednesday. As though it matters. And then he'd say, the sky's green today. No, Malcolm, it isn't green, it's blue. As if it matters. Let it go. This is my big message to early care for people. If something stupid is said, don't argue. Let it go. And then I can remember my saying to Malcolm, come on, Malcolm, get your shoes on. Treating him like a child. And so often we carers, especially female carers, whose caring is rooted often in childcare, because that's what we've been doing most of, tend to treat people as though they are children. And this is so demeaning. And also being bossy. Oh, I've been there. Taking over. Come on, let me do that. It'll be quicker. Instead of allowing people to do things in their own pace and in their own way. And overstepping that fine line between caring and controlling, just don't do it, because this kind of information needs to be incorporated into domiciliary, care home staff training and carer information as well. And it's important because we don't want the person's sense of selfhood being unwittingly undermined, because that's what all that stuff does. And I wish more people knew that the majority of people with Alzheimer's and those with mixed dementia have visuospatial perceptual problems. It's not even on the list in the GP surgery about, are you worried about your memory? Often a more important signal is, are people misunderstanding their environment? Because they can see okay, but the brain misinterprets what they're seeing. Now, Malcolm was very much into astronomy and also into exploration of space and UFOs. And if he were in the room at this moment, he'd be thinking that these little round things in the ceiling is a fleet of UFOs UFOs coming into land and be getting terrified about it. So this is often explains why people are frightened for no reason at all, because they're not interpreting what they're seeing correctly. And they often think that people or animals on television are really in the room. No, they're not real, you say. No. It isn't a crocodile in the room. No. But their fear is real because they think it is. And we must think hard about these 48-inch plasma screens that we've got in care homes with watching a wildlife program, and there's somebody cowering in the corner because there is a huge crocodile in the wall, and will somebody please take it away? And this is why they try to pick up what look like bits of paper on the pattern in the carpet, because to them it looks like bits of paper or confetti that someone's put down on when really it's just a spotty carpet. Malcolm used to say, there are little green men in the garden telling me what to do. And then, of course, I would say, no, Malcolm, look, there aren't any little green men in the garden. And, of course, he'd be thinking, oh, my God, I'm going mad. What I should have said was, oh, really? What are they saying? In other words, going with it, whatever it is. Go with the flow, however bizarre it seems. And the list could go on, and I just don't want to press this point much further, but I think you get the gist of what I'm trying to say. Because caring only gets easier for both paid care staff and family carers when we've learned to give the right kind of care. And that means, as I've been illustrating, the psychological care that you have to give, because probably the practical care, like washing, hasn't yet begun. So for care staff to have more depth of training, and also an ongoing source of expert information is required for the family carer and for the domiciliary care workers. We need a robust service set up to help us all offer the right kind of care. And if commissioners think this is expensive to treat carers like this in particular, research shows that when carers are well supported, they can provide better care for the person they care for and report better well-being outcomes for themselves. Come on, commissioners, that's a bargain. 2 good outcomes for the price of 1. And an ongoing trickle of informed practical and emotional advice for the carer will prevent much more expensive crises happening further down the line. We're all into prevention now with the health and well-being boards. That's one way of preventing crises. And by crisis, I mean the carer getting exhausted, feeling they can't cope, giving up, leading to premature admission to care homes and also probably in some cases to hospital. Expensive alternatives. In the new landscape of care, it's the GPs who are required to see that all carers are assessed and offered a gateway to guidance and support. Immediately somebody's been diagnosed, not 3 years later, including for the first time, hooray, for self-funders, because they've had a rather thin end of the wedge so far. And so what do carers want? They want personalised advice on the right kind of care, and also signposting for legal or financial advice and where to find local activities and peer groups. No carer should work alone. A diagnosis is a life-changing event. We need information, practical tips, and emotional support. And what every carer pleads for, a single point of contact. And although advice on leaflets, websites, and by phone is fine, those objects can't give you a hug of encouragement and keep you going when you feel down. The human contact is as important as stuff that you can read about. I firmly believe it needs to be a human being with whom the person with dementia and carer can build up a triangle of trust between the person with dementia, the family carer, and this person who is giving them practical and emotional help. And by giving the right kind of care, Carers can protect family relationships, and that's what we need to have at the heart of our thinking, protecting family relationships. It's, if you like, an enhanced version of the dementia advisor. And who can do it? Well, anybody who's been well trained in dementia care, preferably has had personal experience and has a kindly personality. And interestingly, by giving this advice to the carer, that advice can be passed on to any domiciliary staff or personal assistants which might be employed by the carer to help them in care at home. So there's a bit of useful, free, collateral training going on. And I suggest a business opportunity, a partnership with the voluntary sector, care home with an outreach service, not just the service that's inside the four walls, but reaching out into the community. You've got people in there who can give so much advice to carers. And also for domiciliary care, a dementia champion for the agency. Those are my suggestions. You might have better ones. Now, I'm not sure about that word training. I much prefer the phrase obtaining understanding. Training brings to mind dogs jumping through hoops or training horses. It's more subtle than that. We've got to have an understanding of what it actually feels like to have a dementia. And if we are wishing to drive up standards right across the workforce in domiciliary care, care home care, and the carers caring, because carers are a workforce as much as, and we are the biggest dementia workforce. The number of us, 500,000, outnumbers all the other people who give care. And it's not what we do, but the way that, yes, you know what I mean, there's a song there, but the way that we do it that counts. And what I go on to say now applies to everybody who gives care. What are the hallmarks of quality standards, the right kind of care? Well, first of all, seeing the person, not the dementia, and fully understanding what it feels like to have a dementia, to be able to walk in their shoes. Now, we've only just recently understood that people with dementia are not forgetting things. It's different. It's not forgetfulness. Forgetfulness is inability to retrieve a memory. Recent research is showing us that we have an experience, and our brain lays down automatically a memory of it, which we may or may not retrieve later. But in people with dementia, the brain ceases to lay down that experience as a memory. It just isn't there in the first place. Okay, so I ask you, somebody asked you today, what did you do over the bank holiday? And you've got an absolute blank, because no memory of what you did has been laid down. How does that make you feel? Come on, some adjectives. Yes? If there's a blank when somebody asks you a question because you've got no memory of it, how does it make you feel? Just throw out some words to me. Frustrated? Frightened? Distressed? Sad? When I asked a group of school children this question, one of them came up with empty. And how very interesting that is. So, what we must do is the fact that we must, because they have no memory of the recent events, we have to be with them when we're talking to them in the right now or the distant past. And that's a primary thing for everybody to say and learn, because domiciliary care worker comes in and says, have you had any visitors this week? That's a daft question. Don't ask it, because there will be no answer. And it's not just a succession of mechanical tasks. Care is also about the chat. That's just as important. Laughter is the best medicine. And if two people are giving care, don't just chat with each other over the person's head and exclude the client. That can actually create distress and even aggression. And we've got to learn that care is more than mechanical tasks. And You need to be given adequate time for the job. Ban minuscule time slots in domiciliary care. They just don't work. Even the Care and Support Bill acknowledges this, because each day can be different. It used to take me sometimes 10 minutes to persuade Malcolm to take his pyjamas off, because rushing the job will create resistance. People with dementia can't concentrate on two things at once. So if a carer worker meets resistance to personal care, try not just walking away and trying again later, but put on some music of the client's taste to distract them, and you'll find the job easier. That's me and Malcolm in the garden. Chat and laughter is something that you can provide in abundance when you're at home. The other essential knowledge is the softer stuff, which the family carer needs to learn as well as care staff. Dealing with repetitive questions. It's no good saying, as I used to, "But Malcolm, you've asked me that 5 times this morning," because what I've just told you, they have no memory laid down of the other 4 times. So for them, it is the only time. And you must respond as though for you, it's the first time as all. I'm trying to save the carer frustration, and also the person with dementia from thinking, "Oh my God, what, I don't remember anything of that," and getting frightened. Living in a different time in their head. So one of your clients might say, "When's my mum coming to see me?" And given that she's 85, the likelihood of mum coming to see her is pretty. But what do you say to something like that? Well, think she's thinking about her mum, so step round it and ask questions about her childhood, because protecting feelings is the most important thing in giving fair care. So use your imagination, step round it, and after a few minutes of telling you about her childhood in Stoke-on-Trent, she will have forgotten that she'll have asked, "Is my mum coming to see me today?" Protecting feelings is important. Resistance to daily changes of clothes or daily showers. Again, could be people with dementia living in their heads when they were young, at a time when clothing was rationed, laundry was done by hand. So you didn't change your clothes every day. You hadn't got those many clothes to change into. I wore the same pair of knickers all week, and I didn't die of dirt. 1 bath a week in the tin bath in front of the fire. And interesting that Malcolm eventually could not go in the shower at home because he thought it was people hitting him and would try to hit back, because he'd gone back in time in his head when domestic showers weren't invented. So what was this strange thing happening? And in any case, many elderly people prefer strip washes because it's warmer and they feel safer. Now, stop trying to make things normal. Malcolm had never been coy, but he went through a phase of not wanting to take his trousers off at bedtime. And this resulted in a late-night television kind of scene, with me coaxing and physically trying to pull his trousers down. Now, years ago, when we were first married, Malcolm would have loved me to struggle to pull his trousers down. But no, not in the present situation. And along came the Alzheimer's Society outreach worker, and she said, "Barbara, there's no law that says you've got to take your trousers off before you go to bed. Who's it a problem for? Is it a problem for you or a problem for Malcolm?" It was clearly not a problem for Malcolm. And because it was a problem for me, it was this thing again about go with the flow, however bizarre it seems. And trying to make things normal is what so many family carers do in bucketfuls, because they're thinking somehow the dementia will go away if they can kind of make things normal. And you'll only exhaust yourselves. And in the end, another carer suggested I might try a nightshirt instead of pyjamas. Dead easy then. You know, deal with the top, put the nightshirt on, pull it down, then you can pull it down underneath and deal with cleaning his bottom. Great. Dignity preserved, all for lack of a bit of advice. The difficult middle stage now, perplexing behaviours, the right response. And I want to ban the phrase that you see so often, He's doing, or she's doing it deliberately to annoy me. I don't want to hear that in our vocabulary in dealing with people with dementia at all. Hiding and hoarding. Used to find my handbag in the washing machine. And the real reasons, instead of me scolding Malcolm, because he denied that he put it there, people with dementia feel that they are losing so much of themselves that if they see anything important lying around, they've got to put it in a safe place. They then have no memory of where and deny doing it. People are not stealing, nor are they lying. And when you understand that, when people are hiding and hoarding, you can make allowances, just brush it off and protect the relationship. Going walkabout. If I tried to lock Malcolm in, he went bananas, and in fact he kicked the front door down. I wouldn't like to feel that somebody was imprisoning me in my own home. And I would have loved to have had one of those electronic devices in my hand that would show me which way he'd gone when he'd scarpered, when my back was turned, and the M11 was only a mile away and it was getting dark. I spent hours searching for him in the dark. And this is where something like that would have given Malcolm freedom to walk. It's not a if you like, a restriction of freedom. It would give him more freedom to go wherever he wanted, and me peace of mind that I could find him if I had to. Now, this is where the community comes in. The local dog walkers and strollers made a rota and came to call for Malcolm, a different person every day. Welcome, would you like a walk today? Oh yes, fresh air, exercise, and relief for me from the eternal vigilance. And new friendships were made as a result, people I didn't know in the village. And I welcomed the national action currently being taken to create dementia-friendly communities. There are people out there who want to help, but don't know quite how to go about it. Losing continence can be a turning point for family carer to give up, especially as people start to pee in strange places. Is it really incontinence? No, they've probably forgotten where the loo is, and if the door is shut, the loo doesn't exist. So think about your en-suites. Can the people actually see the loo from where they sleep at night? Layout of rooms might save them from peeing into something that's not the right thing. Nor should people be put in incontinence pads for the benefit of the staff. They need to be escorted, left to do whatever, knock on the door and escort them back again. It takes time, but it preserves a person's sense of independence for so much longer. Malcolm used to shake his fist and swear. He was angry with himself in the mirror, I was told, because he couldn't do things he used to. No, he was time traveling backwards. And he didn't recognize this older man in the mirror. Because of visuospatial problems, he also thought this chap in the mirror was real. So he'd be thinking, who's this strange man in my house? Is Barbara being unfaithful? So no wonder he grabbed me by my wrists and held me against a wall with a look in his eye that could kill. And of course, when I told the medics, they said, oh, well, out comes the antipsychotics, boom, 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 which made Malcolm stoop and shuffle and brought on a minor heart attack, when all I should have done was take the mirrors down. And it's interesting how, watch out for mirrors in care homes, because the person might think there is already somebody living in this room where you've just brought them into and won't go into it because they don't want to share a room. And in several care homes, I've noticed they've got dressing table mirrors with flaps that can fold over if the person is frightened by misunderstanding the image. Knowing a person's past history, the importance of life story books, and playing out past experiences. A chap in a care home was stripped off every day down to nothing in the lounge at 2 o'clock every afternoon, and the staff would run around saying, "Whoa, not in front of the ladies." The ladies were quite enjoying it, actually. And he was carted off and locked in his room, more or less, and it went down in the book as inappropriate sexual behaviour. But he used to row for Cambridge. So every afternoon when he was 21, he was down by the river, stripping off his day clothes, putting on his strip and practicing on the river at 2 o'clock every afternoon. And when I suggested that perhaps some sort of rowing kit might be provided and maybe a rubber dinghy or something, they said, oh no, we don't do these sort of things here. Well, for goodness sake, I think we've learned about that. And Graham Stokes's And Still the Music Plays is a must-read and give you lots of things where people's past comes up and bites them in their old age. Past hobbies may become too difficult, but new ones can appear. Malcolm couldn't have artwork anymore because of his visuospatial problems, but instead, he'd always been very shy at dancing. But it was dragging by the neck to get him onto the floor for the Parent-Teachers Association last waltz in those days. And no, I don't want it. And he'd go around saying, what idiot writes what idiot thinks up a dance in 3 time when you've only got 2 feet? Good point. But then suddenly, because of the Alzheimer's, it stripped away his inhibitions, and we suddenly had a new activity. So dementia isn't all loss. And of course, people need something to do with their hands. Hands are crying out to be used. Do people in a care home roll up the hem of their skirt or tear up tissues? They're desperate for something to do with their hands. And I'm full of admiration now for the incentives for residents in care homes these days, and also for the work of David Sheard about staff engaging wholeheartedly with the person with dementia, and easy access to open air, pathways with no dead ends, because people don't understand with visuospatial problems, don't understand to turn round, to go back again. And that's why so many falls happen in dead ends. And the wider opening of doors to the community, choirs, children, dogs, so that what I would like to feel is that the community is opening up to be part of the community, and the community accepting the care home as a normal part of the community life, rather than feeling that it's a horrible place that you're threatened with in your old age. Let's make that a thing of the past. Now, the severe stage, the right kind of nursing care. I cared for Malcolm at home, and the important thing is the people who helped me were live-in social care staff. They were not nurses. And this is an area that needs to be developed here. This can be done provided there is advice from an expert in dementia nursing, because a plain nursing registration isn't enough, because it'll be the wrong kind of care. And the RCN is becoming very concerned about the lack of dementia-specific nursing staff in dementia nursing homes, some of whom are charging £1,000 a week, which is a lot of money by anybody's standards. And although there's much physical degeneration and frailty, the usual nursing procedures may not apply. Training is required. I could devote a whole talk to this. So here's a quick list of the most important issues. Loss of mobility. No rolling on the bed to change an incontinence pad, because if the person gets a glimpse of the floor, then they don't know how far that is away, so it feels as though you're pushing them over the edge of a cliff. So that's why he struggles to get back to the middle of the bed, and why a standing hoist is the answer. And in late dementia, you know that primitive grip that you get in a baby? That returns. And they can hold on. We used a standing hoist up to about 2 weeks before Malcolm died. The OTs were going mad because they said, he isn't weight-bearing in his legs. I said, no, but what's returned is this primitive grip, the one that we had when we were apes, and on the back of mums, being carted around, front or back, clutching the fur. That's where it comes from. And it's amazing. Now, that's going on from here. The primitive grip returns. Catheterization is not recommended in dementia. Swallowing problems, they need to have the right level of soft food. There are 16 levels of soft food, and your chef needs to have the right training to provide the right level of soft food for individually. And it shouldn't be prepared on the wing by care workers, because it has to be of a particular consistency according to the severity of the swallowing problems. It requires patient hand feeding and as much continuity of staff as you can, and as much time as you can offer. Because peg feeding is not recommended, because there's an equal chance of regurgitating on the feed as there is of choking on when it goes down the oral way. And all medication should be reduced in line with severity of dementia. You should be using dementia pain scales for identification of pain. Oral hygiene becomes especially important when people can't talk and when they can't chew. Broken down teeth are not necessarily painful because the nerve recedes to compensate. That's what our dentist told us. And look out for toothpaste that is swallowable. Most toothpaste is not swallowable, and if the person with dementia naturally wants to swallow it, they don't know how to spit out, and that also applies to children with learning difficulties as well. Check that the toothpaste is swallowable, or you're going to irritate the esophagus and into different troubles again. It's not your usual constipation. Laxatives are not the answer. It's the push that goes. And here's tip of the day. Put Malcolm onto a padded shower chair, because this takes time, and you try sitting on a lavatory seat or a commode hard seat for 20 minutes. Normally gravity will eventually work and it helps, but if it doesn't, what I did was be behind Malcolm, lean on him so that it bent him forward. He didn't like that, so he tried to push me back, and that started off things down below. Whereas laxatives used to, in fact, cause fecal leakage, and then you've got problems with keeping the bottom safe from sores. And respite care for me should be delivered by replacement care at home, because people with dementia are too frightened. Oh yes, and people not being bedbound because of frequent transfers required a day. Once they've lost their mobility, then they should have loads of transfers between wheelchair, recliner chair if possible, and so forth. And that is the book that I would recommend for the nurse in a nursing home to read, because it is quite a heavy-going book. But I've done a chapter in that one where I've put my own ideas down, so that's why I'm promoting it. But it's got some damn good stuff in it as well. This was Malcolm's Web of Care. 16 professionals involved in advising. And the black lines of communication and the multidisciplinary meetings that used to take place in the back office. This is an expensive model, and it's got to stop, because if we had one dementia advisory nurse at home, or indeed in every care home, we needn't call in all those other people, because that person would know what to do and how to nurse somebody with dementia. And this is you and me. When we're born, we're just simply who we are, our essence, spirit. We're an individual. And as a small baby, we explore the environment using our five senses, and our emotional and psychological self begins to develop. From about the year of 1 to year 1 to about year 7, we learn to control our basic physical functions. Interestingly, continence is often the last thing that's acquired, especially bedtime continence, and that's often the first thing to go when in dementia. And then finally, there's all our learning. Now, dementia wipes away almost all of that top level and makes holes, lots of holes in the second level down, leaving those two bottom levels more exposed and therefore more important. And they're often the part of care that are completely ignored. And even visitors in a care home stay away because they say, well, we don't know what to do when we get there, because they are so apparently immobile. And this means stimulating the five senses: sight, taste, no peg feeding, smell, aromatherapy, worth every penny. hearing, continue to talk even though they can't talk back. Because that was the first thing we heard when we were born, was our parents speaking to us. And it's deep, deep psychological need to hear the human voice, even if there's no response. And touch, the most important of all. We had a nurse who came and said, where's your sedation when Malcolm wakes up in the middle of the night? I said, no, we haven't got any sedation. Well, what do you do? She said, you put your arm round him, you whisper in his ear, you're safe, Malcolm, it's okay. Just go back to sleep, stroke his hand, and within a few minutes, back he'd go to sleep. She said, oh, couldn't possibly do that, she said. We're taught not to touch. She lasted a week. And finally, feeling safe and a tranquil environment, feeling loved and cherished. Look, I'm doing all those things for Malcolm, touching, smiling, talking. But the face, stony, because he's lost control of the muscles, so he can't smile or frown. And it makes me so cross when they say that people have no psychological needs or emotional needs. The continuing health care, yeah, down it goes to low or none. He's still got needs, they're just locked inside him. And his feelings are still there because he's still a human being, and feelings are there to the end. And so, towards enhanced quality of care, families need to be given value for money, and to know that whoever is giving the care belongs to an organisation which shares good practice, the staff are valued by the organisation, and that the staff who have come to help and carers think holistic care, everybody understanding what it feels like to have a dementia, not what dementia is, but what it feels like, and competence and compassion, a workforce bringing hands, head and heart to the job, and developing this trusting, triangular relationship between the person with dementia, their carer, and any single health or social care professional involved with that triangle of trust, right to the end. And people said to me when Malcolm died, the real Malcolm died ages ago, but remembering the pyramid, the Malcolm that died was the Malcolm that the world saw, those top levels, the Malcolm that was there to the end, with the two bottom layers of that pyramid. Thank you for listening to me.